individuals who've been active in this organization have gone on to um, change American surgery, and the next lecture is no different. This is named after Roger T. Sherman, a former president and secretary director of the Southeastern Surgical Congress. Dr. Sherman's best known as the chief of surgery at Grady Memorial Hospital, where he specialized in trauma and trained dozens of students, residents, and fellows in that specialty. He was beloved by his trainees and surgical colleagues and rose to become president of this Congress in 1984, then the executive director from 86 to 93, 3 years before I attended my first meeting in Tampa. I'd never met Dr. Sherman, but felt like I knew him after Mary Allen's iteration of this lecture in Atlanta in 2021. For those of you that weren't here, it was published in the American Surgeon in April of 2022, and I would encourage you to read it. In it, Dr. Allen shares her favorite quote from Dr. Sherman: "Surgery is an awesome responsibility afforded to only a few. An honor, a high honor surpassed only by being trusted to teach others this demanding and marvelous craft." In part because of him, traumatology has always been the um, primary focus of the abstracts submitted to this meeting, and the program is heavily weighted towards trauma. As a result, the lecture bearing Roger Sherman's name is traditionally given by a trauma surgeon. And most of you know Mike Rotundo, if not personally, then by reputation. A cardiac surgeon at heart, Mike's reputation was established following he and Bill Schwab's seminal work describing damage control laparotomy. This notoriety was sufficient to compel Walter Porres and Randy Chitwood to successfully recruit him to Greenville to organize that robust trauma service into a level 1 trauma center with significant investment from the county and the hospital to do that. As he was recruiting me to Greenville and in the 3 years he served as my mentor and chairman, I learned that his organizational skills were unmatched, actually quite legendary. His successful establishment of the Trauma Center in Greenville gained him a national podium as chairman of the Committee on Trauma from 2008 to 2011. You've heard about the unspoken bond we shared in yesterday's presidential address. One of my saddest days in Greenville was when he announced his plans to return to his hometown to serve the University of Rochester as head of the practice plan and vice president of Strong Hospital. After that, our paths diverged, but I will always be indebted to him for the opportunity he created for me in Greenville to build a cancer center in the mold of what he had done in trauma. His interests at that point deviated away from clinical medicine and became more heavily focused on health systems and healthcare delivery, an area of focus which his organizational proclivity has served him well. I know that many of you were hoping to hear about damage control laparotomy today, but I specifically asked him not to focus on that because, as hard as it is to believe, I think his true strength and contributions lie in what he has been doing since going to Rochester. Mike had some travel difficulties getting here yesterday and texted me late yesterday to let me know. The consummate planner, I realized this morning what he was really doing was closing a loop to let me know the title of his presentation for the purposes of this introduction. Please welcome my friend, Mike Rotundo, who will give this year's Roger Sherman level lecture.
Good morning, everyone. And thank you, Manny, for that introduction. You're going to see that I actually didn't follow the instructions that he gave me, but we'll get to that in a second. It is wonderful to be back at the Southeastern Surgical. This meeting really warms my heart and always did for all the years that I was at it while I was in Eastern North Carolina. And as Manny mentioned, when my career took a little bit of a shift and I ended up moving back to the north, then it took me away from this meeting. For those of you who have been coming for a good number of years, you're going to really understand about exactly what I'm about to say, and that coming back and seeing, Ken Sharp and seeing Rick Green, the people who really I've emulated and tried to follow in their footsteps. And of course, Don Nakayama, I have to mention him, of course, one of the deans down in Georgia, and our editor of the American Surgeon. I've known Don for 40 years this year, March of '86. Don Nakayama was a fellow in pediatric surgery at Children's Hospital of Philadelphia, and I was a second-year resident. And it's in those relationships that we really grow, and in those relationships that we find strength. And I just want to mention that because it's just so important. It clearly is an honor to deliver the Sherman Lecture. Let's see if we get this to happen here. Here we go. And one more. There we go. And you've heard this already about Dr. Sherman. Now, interestingly, you know, this is testimony to how dependent we are on the internet. You can't really find an awful lot about Dr. Sherman. I had heard about Dr. Sherman from Dr. Feliciano. We heard about what's available, but you can't really find an awful lot about this legendary figure, nor can you really find a lot of pictures of him, because I really looked. I even went back into the Emory archives to see if I could find my way in through their library to see pictures, and it was pretty tough to find it. But it is people like this, leaders like this, that create our path, and it's leaders like this that inspire us for the work that we do in the future. You know, I have to tell you, time is an interesting thing. As time goes by, you have a tendency to try to make sense of your life a little bit and to try to understand some of the things that have happened in, I imagine, your personal life, but certainly in your professional life as well. How do you make sense of all of this? Dr. Shames just gave a really important lecture where he talked about the evolution of an idea, how the initial strategy was devised, what tactics were put in place to execute on that strategy, how those tactics were then deployed at a large scale, how were they studied, and this continuous idea of innovation all along the way, continuous developments, even to vascular surgeons who are crafting by hand their tools to use in the operating room, because the solutions that they had available to them just didn't seem to work. It's a perfect paradigm for this discussion that we're about to have for the next 30 minutes. So how do ideas go all the way through to impact? And he had some beautiful slides around the impact on the residents, but also the outcomes are incredible. It also demonstrated a clear shift away from simply the anatomic reconstruction to really the physiologic benefits of not doing those big open operations and having the high degree of physiologic derangement that occurred for the patients as well. So today I'm going to explore that a little bit, and I am going to explore it in the context of something I haven't talked about much at all in the last 10 plus years, and that is damage control surgery and damage control resuscitation, because I think it provides a case study for this. Now, you may ask yourself the question, you know, why haven't I talked much about it for 10 years? Well, I made a decision around 2013 when I went to Rochester, and my career went really much more towards practice management and system development, that if I wasn't doing it on a regular basis every day, I ought to make room at the podium for other people to talk about it. I didn't want to be one of those surgeons that, you know, did a hernia, you know, once a month and still was up pontificating in front of large groups of people about their clinical acumen and et cetera, et cetera. I think you could get the message. For me, it just didn't make sense. And it created some degree of cognitive dissonance. Even the concept that, as Manny mentioned, that though I am well known for damage control surgery, I can tell you I don't own that idea. I actually don't think anybody owns ideas at all. So we're going to explore that today a little bit. So of course, you know, we've turned to ChatGPT and we've asked them the question about damage control surgery. We asked them a question, you know, what's the proper treatment approach for a patient who has a gunshot wound to the abdomen, who has multiple visceral injuries and multiple vascular injuries with physiologic instability? And it's amazing what happens, how embedded this now is. All of the treatment algorithm just cascades out. It just cascades out automatically. And almost as if this now is surgical dogma, it comes up right away. And then this one line summary that you can see, which an unstable patient with destructive abdominal gunshot wounds requires rapid damage control PAC, control bleeding, contamination, temporary closure, ICU resuscitation, and then later definitive repair. Along the way in this algorithm, if you look at it, it's got all the principles of damage control resuscitation as well. How does that happen? How does that evolution occur over so many years when it really starts with the kernel of an idea? Well, I can tell you that, as I mentioned a minute ago, I don't really believe that anybody owns an idea or a concept, and certainly damage control surgery was not something that was conjured up in any one person's head. If you look back in history, you can see that the concept of stopping an operation for a patient who was physiologically unstable had been around for a very long time, even in the absence of definitive of going on to definitive repair. Temporizing surgery had really always been around for an extremely long time. So ask yourself the question, what is an idea? It's a new insight, an observation, a hypothesis to maybe answer a question. It's got to be unconstrained to some extent. It's got to be able to be exploratory. There's high creativity where you're discussing an awful lot of options, and a low commitment. So I decided to sort of go to the Greeks to think about this. And you can see that across the centuries, really, Plato, Aristotle, down to the Neoplatonists, you can see that there were different concepts about where ideas came from. You may remember the shadows on the cave wall from Plato, that external forms beyond the physical world would tell you where these things came from. Were they divined in some way? Aristotle, a little more sensible, experience processed by reason. Boy, that seems to resonate when you think about surgical problems like a complex branched aneurysmal disease and how you actually manage that. That's about, you're looking at that problem and thinking about it in some practical way. And then dialogue begins to draw that out. You start talking about it and then making some sort of rational judgments. So the great philosophers have debated this for years, for decades on end, for centuries on end, really. And it could well be that Protagoras from around 490 BC got it right, because Protagoras really said that ideas really are constructed through human perspective and dialogue and context. So in the context of a specific problem, you're trying to find a solution, you begin thinking about it in the best of circumstances, you're talking about it and you're sharing it with your colleagues and they're sharing your experience, and you start to have this sort of generative discussion where ideas are not about something that's created out of the air, but a collision of perspectives where you have problems that you're trying to solve, and you're trying to solve those problems because the problems are looking for relief. You're recognizing a pattern. Pattern recognition is still extremely important. If you think about large language models and machine learning, AI is built on that sort of pattern recognition as well. And in a safe environment, you can move ahead and begin to see if it will work. And stealing, not just borrowing, but stealing shamelessly from other scenarios is extremely important as well. So Protagoras introduces this concept of perspective, and that it shapes understanding, and that dialogue is extremely important. Well, after that, something else has to happen. You have to have some kind of a strategy to move forward. And we always talk about strategy being a choice, being a deliberate set of choices on some form or another. You know, I always say that if you look at strategy in healthcare right now, I feel like we're in a really stagnant phase. I mean, all the health systems are doing are looking to the left and seeing what's happening in that health system, and looking to the right and seeing what's happening there, and then everybody's doing the exact same thing. Year before last, I was at JP Morgan Health. I listened to some of the major health systems present their strategy in the post-COVID era. They were all the same, exactly the same. And so, and I really think that from a strategy standpoint, oftentimes, because people confuse, I think, strategy and tactics, strategy is a basic framework, ends up being not really the most innovative phase or the most interesting phase of really any idea development. It just happens to be a phase of it in one way or another. So a deliberate set of choices, and I think the most important piece of it is determining what you're going to do and why you're going to do it. As soon as you think about strategy from a why perspective, now you begin to get into almost a organizational dynamics or a psychology of execution of a specific strategy. You're trying to motivate people to do it based on a very compelling why. So again, let's go to the Greeks for a minute. This is Themistocles from 500 BC. He was thought to be the most brilliant strategist, really, in Greek military history. He had long-term vision. He could see. He understood psychological insight, what was going on in the dynamics and how he could win from a psychological standpoint. And very, very important, and I think flex surgeons are great at this, tactical flexibility. When it came to the next step, which we'll talk about in just a minute or two, he knew how to flex to make it work, you know. So you can see here that though traditionally we talk about making clear, hard choices and creating a distinctive value proposition, et cetera, translating strategy into execution is the hardest part. And you've got to have a really strong why to do that. And when you begin to execute on that particular strategy, your tactics have to be really clear. So let's go to that. I think that, you know, tactical execution is where really great ideas go to die. We really struggle with this in healthcare. We struggle with it in any system development scenario. You've got a great idea. You've devised a strategy. So you've got a why, as you're very strong. Your what and why is strong. Now you get to how and when. How and when. And this is where we struggle. And we grind in healthcare in this big time, right? Particularly in academic medical centers, where there's a lot of creative thought and a lot of independent operators. You know, I always say when in academic medical centers, we try to recruit unicorns. And the minute they get there, we try to make them all the same. Not sure why we do that. Doesn't make any sense to do that. It's about harnessing that, even at the tactical level when you're trying to execute. And you've got to have that tactical flexibility in order to do it. So generally, we talk about specific actions and initiatives. You're bound on a timeline. You're trying to measure what's happening. You're getting people to work within a specific system. And I can tell you, tactics are often a place where organizations really overinvest, but unless you've got really a clear why and strategic motion, it's hard to get them to actually come to fruition. So again, 380 BC, this is Epaminondas, and he was a brilliant military technician. He is well known for the so-called oblique phalanx. This is where he would take all of his troops and he would put them on one side and then break through lines and then be able to come back, outflank them, and then come from the rear. But what it really speaks to is that the ability to really prioritize actions that really advance the strategy in a very direct way. And the work has to be sequenced in a realistic way, and then assigning clear ownership is important as well. So what about this? What about innovation? I think this might be the best time to talk about innovation. Why? Because I think innovation is actually a organizational attribute. Innovation should happen really anywhere along the line. If strategy is about what you're going to do and why, and tactics are about how and when, innovation, and we just saw a phenomenal example of really now decades of innovation in endovascular care. It's about seeing relationships and how things fit together in order to enhance a specific strategic or tactical initiative. And so innovation should happen really at every step of the way. You may call it continuous process improvement. You could call it all kinds of things. But I think really one of the things that I try to preach all the time and live is the benefits of innovation. It's those unicorns that we're talking about, those people that are out there every day thinking about things in only the way that they think about them, that can take specific systems that exist already and come up with new ideas to make it work better. So innovation is not a specific goal. In reality, it's a modifier. Does that make sense? It's a modifier. So you can have something that's new and that's a novelty, but if it doesn't modify in a way that it creates impact, then it probably isn't really much of an innovation, is it? So there's another element that has to be in place as well. Now, Archimedes, of course, was thought to be one of the greatest innovators. And if you look at the things that he did, you know, he united pure science and engineering applications. He invented new methods of mathematical reasoning. He practiced experimental science before science actually existed. He was quite technologically driven, even in his day. So, you know, there is a phenotype of human being that can't help but innovate. It can't help but look at a situation and try to see relationships that other people have not seen or that only they see. So this is the I think an important concept to think about, you know, when you're looking at an organizational dynamic or trying to understand what has impact and what doesn't and why it would have impact. So let's move to that. So impact is really about meaningful change. As I've said, it's something that has now happened that is meaningful, it's sustained over time, and it's aligned with strategic intent. Now, sometimes you can happen upon specific observations and they may shift your strategic intent because you see something now that you hadn't seen before. Your what and why changes a little bit based on the modifications to the how and when, based on what happens with impact. So in order for this to work, really, something has got to change. Here's Aristotle, thought to have the greatest impact amongst the Greeks. And it's defined, in essence, by the outcomes, not by the intention. That's the idea that you can actually stumble upon something, and even though you didn't intend to have it work out in one way, it works out in another way that could be very beneficial or quite detrimental as well. Now, if it happens once in your basement, that doesn't mean a lot. It's got to scale and be sustainable, and it's got to turn into broader scope of impact. And again, I want to turn to our previous, to Dr. Shame's lecture. It's amazing how the work in endovascular surgery has really transformed anything that we knew in terms of vascular disease over the last, let's say, 3 decades. Quite exceptional. All right, so let's turn to a case study if we can. And this, Dr. Zervos, forgive me, is where I decided to go back to talk a little bit about damage control, because there's nothing else that's going to help me make sense of my life. Because I just want to share with you, I'm only going to talk about 2 papers. And the first one you'll see in a minute is the paper that I presented in 1992 as a second-year attending, an assistant professor at the University of Pennsylvania, in an environment that was actually quite creative, an environment where we had air cover to try new things, an environment where we were exceptionally frustrated with poor outcomes in patients who had physiologic instability after penetrating injury. And I want to turn to this paper. This is from old, some of this is archival now. This is the paper that was presented. I want to point out a couple of things. As I said, it was presented in 1992, and this was a 46 patient series. And that's all it was, with 22 patients in a definitive laparotomy group and 24 patients in a damage control group. And if you look at that one graphic, the one box on the left labeled Table 1, you'll see there really is no difference in outcome. It's only when it was whittled down into that very small group of 13 patients versus 9 patients that there appeared to be a difference. Is this the science upon which damage control was built? Is this the paper that has been attributed, like it or not, to me? Look how weak the science is. Look at the absence of science in it. It's incredible. Yet this thing took off like wildfire. I remember presenting it at the AAST and having the lines form behind the microphones before I even stopped. And it was Feliciano and Richardson and John Morris and Ken Maddox, and they all lined up to endorse it, that this was the right thing to do now in the current environment where wounding had become a huge problem. Gunshot wounds had become a huge problem. How does that happen? Why does that happen? So I went to the Oracle and asked, why did damage control surgery become so prevalent so fast in the absence of little scientific evidence to support it? Well, remember, it was not a new idea, despite what people might assign to any one person for being the person that thought of this. No, this had been around for a long time. And it had been discussed a lot at meetings in the back of the room. Let me tell you what I did last night, 2 nights ago, to a patient that just came in. Nah, we just decided to stop. Patient was really not looking like they were going to survive. These cases where we were terminating operations, temporizing and terminating without doing definitive surgery, much to the criticism by our colleagues of what we had just done. So what did ChatGPT say? It said, well, it addressed an obvious clinical catastrophe, that the physiologic derangement was pretty evident. I think we all knew that. It was technologically simple, and it was. Control bleeding, control contamination, place packs, temporary closure, leave. And this is kind of interesting because it goes to the idea of the psychology of the phenotype of trauma, right? Trauma culture allowed rapid knowledge transfer. Well, looks like that could work. Let's try that. Otherwise, these patients are dying anyway. Let's see if this works. And the patient couldn't be randomized, patient population. Military experience seemed to reinforce it. And the early outcome signals were pretty strong. Hey, I got out of the operating room in the live patient, I went to the ICU, and then we tried to figure it out. And it really represented an important paradigm shift. It really was not a technical advancement. You didn't actually have to learn anything new. You had to stop doing some of the things that you had learned. So a shift had occurred here. So now, to reconcile this other problem that I've had for a long time, which is someone crediting me with this particular idea, well, I went and asked again. I asked ChatGPT, you know, who's considered to be the father of damage control surgery? Well, they list Asher Hirschberg. Now, I don't know if anybody knows who Asher Hirschberg was, but Asher Hirschberg was working with Ken Maddox, and they were working really on some of the most important physiologic modeling and pathophysiologic modeling of hypotension. It was out of that lab that permissive hypotension came, the idea of that. And Asher was really brilliant in that area. You know, I had the opportunity to spend some time talking to him about this, but once again, it pegs it on the paper that Dr. Schwab and I wrote. But there's something really important in the bullets, because in all the years that people would say, this is Rotundo's thing, I would say, no, you don't understand. All I did is put 3 boxes up on the screen. That's all I did. Because everybody was talking about it. This has to be described in some way that people can understand. And it says that the paper clearly articulated a 3-stage framework. It identified the physiology problem. Yes, that we did. In the discussion section, we talked an awful lot about what was happening with acidosis, coagulopathy, hypothermia. And it helped really make it start to look like a set of steps that you can do that could be executed simply. This is not exactly the image. It looks kind of vintage. Doesn't this image look kind of vintage? It it is similar to what was presented from the podium, but from the podium, dare I say, we were using Harvard graphics back in the day, not PowerPoint. And look at it, it has three parts. That's the strategy. And then each of those parts has a steps. The steps, those are the tactics. So there really isn't anything brilliant here. It was the articulation of this that happened to come out in a very poor piece of science that resonated with everybody, and it just took off like wildfire. But I think in retrospect, to sort of try to analyze it and in some way reconcile it in my own mind, it was just the steps, and I was learning them with everybody else. And we were talking about them amongst each other. It was a generative discussion that was occurring across the country at the time. John Morris had written a paper on abbreviated celiotomy that came out just before our paper. Tom Scalia had a paper with 11 patients in it that they had done a rapid termination of operation. And then, of course, there's the sentinel work from Harlan Stone, which was in 1983. This was not new. It was simply articulated in a different way. And it allowed us to put our surgical machismo to the side and focus on physiology. So it was a reframing of that surgical objective from fixing the anatomy to thinking about physiologic survival. And it really refocused us to create a physiology-driven model and try to think about how we're now to execute and transform systems and infrastructure and the teamwork to get that to work. Well, there was something else that was happening at the very same time. And this cannot be overemphasized. You can consider literally the 20-year period, which I sort of arbitrarily chose for this, to think about this 20-year period, what was happening in surgical critical care. Now, in 1985, I think there might have been less than, I can't remember when the certification exam for surgical critical care came out. It was pretty close to this time. Phil Berry always talks about the fact, when he was with Shires in New York City, Dr. Shires told him, you're going to be our critical care guy, sent him to get a certificate. He has number 27. I think I have 1340 or something. Mine came in the early 90s. But look what was happening here in surgical critical care. So if damage control had provided patients that were now alive, now something had to be done to figure out how to keep them alive and to resuscitate them differently. And a tremendous amount of change occurred in hemodynamic monitoring. It was really the rise and fall of the pulmonary artery catheter. Fluid strategy changed from, remember the Shoemakerian, Dr. Shoemaker's approach, where we push patients from a crystalloid resuscitation standpoint to non-flow dependent oxygen delivery. Then we'd add inotropes, keep putting wood on the fire to see if we could deliver more and more oxygen. It wasn't until later that we determined that it really was not cellular hypoxia, but cellular dysoxia. The metabolism for oxygen just wasn't there. The cells were in an inflammatory state. They weren't functioning properly. All kinds of mechanical ventilation, rescue tools. We now went to a lung protective approach. Societies were formed. The PEEP Society was formed, delivering such high pressure ventilation. Of course, the open abdomen, the surgical approach to the open abdomen had to be developed in some way or another. I did some of those earliest reconstructions because we're creating these patients, had to figure out how to get them closed later. And you couldn't go anywhere to find how to close them. And we were creating patients with lots of open abdomens because of the crystalloid resuscitation and the development of intra-abdominal hypertension and abdominal compartment syndrome. And overall, this shift to let's get out of the operating room and let's go to the intensive care unit. So I would call this a phase of really innovation that was occurring. It was managing new problems that were being manifest by the ability to create survivors out of non-survivors and patients who then would have a whole series of problems that heretofore had not been really experienced. So there was this core conceptual pivot that occurred philosophically from pre-1990 to by the early 2000s, from just normalizing the numbers to protecting the organs. The thought that more fluid was better perfusion to fluid overload causes organ failure. That became really pretty clear that crystalloid wasn't necessarily good for end organ perfusion. Fix the anatomy no matter what, operate until either you drop or the patient stops, or stage the surgery around physiology of the patient. Differences in ventilatory support, respiratory support, and instead of, the monitoring the drivers of care, you were really, the biology was driving the care, and then understanding what was happening in oxygen metabolism as well. So we asked another question to Chat GPT because something else happened next. War broke out, and there was a whole new problem to deal with. And in fact, when Don Jenkins got to Iraq as the first trauma czar, he started developing with others the echelons of care. And the echelons of care said that you're going to start to use the principles of damage control surgery on the move. Role 1 facility or role 2 facility, damage control part 1. Role 3 facility, the combat surgical user, damage control part 2, and some of part 3. Strategic air transport back to Landstuhl, Germany, finished the definitive surgery, damage control, rest of damage control part 3, and then a strategic transport back to continental United States. Why is it then in that environment that damage control resuscitation emerged? So I think here are the problems that were identified. And again, our artificial intelligence tools have done a good job summarizing it. First of all, there was a continuous rise in frustration in the pre-war period through the 90s of the complications that were associated with those patients that survived damage control surgery. So whereas we were very frustrated about death, the next generation of surgeons became very frustrated about the complications. War then breaks out, and then innovation occurs again. Persistent death despite successful damage control operations. Did everything right, patient died anyway. Recognition that the resuscitation wasn't needed to be. Identification that trauma that caused coagulopathy was a very early primary event. And as I mentioned, the military opportunity and the shift from volume resuscitation to hemostatic resuscitation. This is critical. And that data began to confirm that these were the problems. And here is the second paper, and only the second paper I'm going to talk about. And this is Borgman's and Holcomb's paper from 2007. Now, Dubik in 2003-04 had already foreshadowed this in conjunction with permissive hypotension. But this is what signaled the shift in the need for aggressive change in resuscitation strategy, this paper. And the same thing happened again. As soon as this paper was read, it took off like wildfire. And now massive transfusion protocols, people like Brian Cotton started developing ways for the system to change to accommodate what they were able to do in war, which was, in this case, use fresh, whole blood to do the resuscitations. Not so practical in the civilian environment, but with the help of thromboelastography, another important technology that had been introduced, now you could start to think about hemostatic resuscitation. So in the conceptual arc that occurred here, from damage control surgery to damage control resuscitation, it was continuous innovation that was occurring. Now you can make an argument that damage control resuscitation was a new idea, but it wasn't new either. So I mean, editorial decision now, I guess we'll call it innovation, call it what you will, but it was continuous improvement in over these decades. So look at the primary question. Why are they dying? Lethal tryout. How do we fix it? Well, we're surgeons. Let's change the operation. But what's going on? These patients still have tremendous complications. Well, maybe resuscitation is a problem. We knew that actually, but just know how to fix it really. How do we resuscitate differently? Holcomb and Borgman, blood resuscitation, and a hemostatic resuscitation with a lot of other contributors associated with that. How do we individualize that hemostasis? So this is the precision biology-driven hemostatic resuscitation using whole blood. So this arc of development represented now really the integration of two concepts, one which was tremendously affecting the other. And that is, that the observations that came out of damage control surgery that you can see there on the left led to a series of the need to develop some solutions which came from damage control resuscitation, and therefore the reduction in the need for damage control surgery. Because as the system developed over time, as the adoption of damage control resuscitation, it changed the physiologic outcome, it changed the operational outcome, and it led to a translational outcome as well, where this kind of hemostatic resuscitation is used now outside of injury care. And so as these ideas began to come to the fore, system adaptation had to occur in order for this to be accommodated. Think about the work that Ronnie Stewart has done in Texas. Think about the work that Brian, to get whole blood, to get blood available across their regions, their injury care regions in Texas. Think about what Brian Cotton did and all the work that he did about mass transfusion, hemostatic resuscitation. The system began to adapt so that we could use the principles of damage control in the care of these patients. And I contend that this led to really meaningful change and impact. And so what has changed? Well, clearly, early hemorrhagic death has gone down. In the pre-integration era, it was pretty common. Now, given what's happened, it's markedly reduced. Crystalloid-related complications are far less frequent than they used to be. Abdominal compartment syndrome, very uncommon. The people who are practicing today tell me at the best trauma centers, they're just not seeing this. Thank God. Massive transfusion survival, very poor now because the protocol substantially improved, as well as monitoring with thromboelastography and late multiple organ system, late multiple organ failure deaths, far less than they used to be. So this really represents a 30-year arc. Hard to believe it's been that much time. And there isn't any one person that did this. This came from generative discussions, collaborative work, competitive work. It came from an external environment that mandated change, the gun violence in the 90s, the war in the 2000s. It came from commitment. It came from courage. It came from willingness to take risk. So as my final image here to sort of solidify this, what I've reviewed a little bit, tried to talk a little bit about some of the Greek philosophers of how ideas are generated, how that leads to strategy, how that leads to then tactics that are devised, and then tactical execution, how that then gets disseminated, innovation every step of the way, and then impact, hopefully, for our patients. But I have to talk about one more Greek. And this is why I use the Greeks, of course, because of my good friend Manny Zervos, who I can tell you for sure that when he agreed to join the faculty at East Carolina, it was a game changer for us. We didn't exactly have anybody with the pedigree, with the surgical skills, with the leadership skills that Manny Zervos had. And I could not have been more grateful that he took a chance on me. He took a chance on the department. And now it's been 19 years of extraordinary work that he's done in a part of the state of North Carolina that really, really needed him and still needs him. Thank you, everybody, and thank you, Manny.
I want to just take a minute, a second, and exercise the privilege of the podium and the presidency to make a comment. As I'm thinking about your talk, Mike. Don Morton was really the inventor of the discoverer of, was prescient in identifying immunotherapy as the ultimate cure of melanoma. He published his life's work about 30 years ago, and it was stopped dead in its tracks because it failed to show statistical significance except in subgroup analysis. Michael's right-sided table was a subset analysis of a group of patients that really wasn't probably pre-identified. And had you existed in our oncology world, or did not have the brotherhood of trauma world to disseminate something that was so intuitively and clearly obviously gonna help people, you were able to push that agenda forward. In cancer, it's taken us the failure to identify what is obvious in front of our eyes 30 years ago has pushed us back to finally recognizing Don's work and realizing that immunotherapy is the cure for melanoma. We knew it then, but we failed to identify it because of a statistical aberration. And I think that's why your specialty is so much better than ours is in moving the needle forward quickly. But anyway, that was fantastic, Mike. I'm glad that you didn't listen to my advice. The last thing you need is another clock, but here it is. This is a gift from the Southeastern Surgical Congress in recognition for your lecture today, the Roger T. Sherman Lecture. I want to get a picture with you.